For questions.
Thank you, Mr. Chairman. I appreciate that very much. Appreciate the witnesses being here today. Dr. Terry, if you could help me out on this. I know we've apparently got smartphones and all kinds of computer programs that will help you with the ICD-10, but they also come out in book form, do they not? The ICD-9 and the ICD-10. And my understanding is the ICD-9 is about one volume, about yay thick. Is that right? If you could answer for the record.
Yeah, about 2 or 3 inches.
And that the ICD-10 would be about 4 of those same size books. Is that about right?
I've not seen it, but it makes sense it will be.
All right. And you indicated earlier that the rest of the world is using 20,000 codes, but that we're about to use 80,000 codes. But then I heard testimony that the World Health Organization is coming out with an ICD-11. Are most of the world using the ICD-10 already, or is that just aspirational?
Well, yes, the rest of the world is using ICD-10, but it's like you're comparing apples and oranges. The rest of the world is using it's less than 20,000 codes, and they don't use it for billing. They don't use it in the outpatient setting. But you're saying, oh, we got to keep up with the rest of the world, but we're doing it totally different.
Okay. So if we did it the way the rest of the world did it, then you'd be okay with it, or you could at least figure it out. Is that a fair statement?
Yes, sir.
And you said something about how many codes there were for diabetes, and I failed to write that down. How many different codes are there for diabetes?
250.
250 codes. I guess that my problem with the ICD-10 and this whole concept, and it comes down to part of what you're saying, it would seem to me to make sense that you could do a dual system. Now, ultimately, you want to get everybody on ICD-10. I get that. But if you submitted for a period of years ICD-9 and ICD-10, and if you got either one of them right, you got paid, then that would probably alleviate your fear and concern. Is that correct?
My fear is just being able to take care of the patient and not being put out of business because I code wrong. That's my fear. And how you fix that, like I said, there's several ways to do it.
Yeah. And do you know what the projections are on the number of the shortage of doctors that we're anticipating having in this country?
I don't know numbers, but it is definite. I mean, there are fewer people wanting to go into the practice of medicine because of the financial aspects, and it's just
and lots of paperwork and dealing with lots of computers instead of seeing patients.
We're
right?
talking about computers and statistics, but one thing hasn't changed, and that's the care of the patient, the sitting down and listening and examining and talking. Computers can't do that, and I don't have time to do that anymore. I'm sitting in my office with my desk with my back to the patient, typing on my computer, trying to take care of my patient. And if you have a 15-minute office visit, that's getting whittled down by 50% now. Now, it's not all ICD-10. It's meaningful use, electronic medical records. It's trying to learn how to deal with this. But ICD-10 is going to pile on it. And
so as a result of that, it wouldn't surprise you that either last year or the year before that, I sat down with a doctor in one of my rural communities that I represent, and his number one complaint was ICD-10. And he said, look, I'm getting old. I'm not a dinosaur, but I'm getting old or older, and I love serving this community, but I don't know if I'm going to continue to practice. So you would anticipate that pushing with a drop-dead date, as Dr. Burgess pointed out earlier, the dual coding is only going to happen up to a certain date, not allowing for things to go forward after that. You think that, like him, that there will be a lot of other doctors that may decide that it's just time to go ahead and retire and enjoy their house at the lake?
There's no question. I already have a doctor in Mobile that's already quit because of the threat of ICD-10, plus he didn't want to have to take his boards a fifth time. And there are a lot of people, I'm 60, 61, there are a lot of people between age 61 and 65, they're not going to do it. Now, how do you measure that? I'm just telling you, it's going to happen.
So what we're going to see is that my allergist who served my family for 5 generations and who didn't stop practicing until 92, and even though his body was getting weaker all the time, his eyes flashed and he always knew what was going on. You're indicating to me that we're not going to have those doctors continuing to practice as long, and that's going to create a problem in our rural communities, notwithstanding the fact that some of the younger doctors, like Dr. Burke, will figure it out. But it's going to create a shortage of doctors, particularly in the rural areas. Am I correct that that's part of what you're saying here today?
Yes, sir, but it doesn't have to be that way. If we can change the way it's being implemented, it doesn't have to be that way.
Well, I appreciate you being here very much. I appreciate everybody else, and I understand for big practices and big cities, all of this is easy, but it's not so in the rural areas where we're already having healthcare shortages. Thank you. I yield back.
Chair, thanks, gentlemen. Now recognize Mr. Long from Missouri, 5 minutes for question.